So hello to everyone. We are at the new e-ICSM chat. I have the pleasure today to host two intensivists, two people that I really appreciate. Victoria McCredie from the Toronto Western in Toronto, Canada, and Giuseppe Citerio from Monza, Italy. So hi guys, and thanks for being there.
Ciao Fabio.
The topic today will be about something that I like, is brain monitoring, and I would like to start from Victoria. If you deal with patients with primary brain injury, which are the patients that you think deserve to be monitored?
Yeah, thanks very much, Fabio, and thanks for the invitation. So this is such I love this topic, and I could talk for ages, but I'm going to try and keep it short. So, you know, I work in a quaternary neurovascular center. And so we have majority subarachnoids, but as we know about ClinEpi, high income countries, traumatic brain injury is becoming isolated TBI in elderly patients. So we actually get quite a large cohort of those patients. So for me in neuromonitoring, it's really important for our subarachnoid patients, as well as our traumatic brain injury patients, as well as our ICH or intracerebral hematoma. But those hemorrhage patients are sometimes hard to get our neurosurgeons on board to consider about invasive neuromonitoring. And maybe I'll just quickly say like why I think that's so important is, I mean, they're not new studies, but we've learned so much from all of the neuroprotective agent studies, right? Like the dexabanol and the sulfatil studies. And we know that like, especially TBI, we see what was it in Andrew Mass's and the sulfatil studies, that up to about 40% of patients, traumatic brain injury patients, are going to show neurological worsening in the first acute admission period, so up to the first 10 days. And that really sells it to me of why it's important to monitor these patients. And then our subarach is such an interesting group because there's almost like a double hit where they have their initial bleed and then they go through their early brain injury phase and then their delayed cerebral ischemia phase that we always want to monitor, especially the prograde, right? The prograde subarachs for me is the really important one. So hopefully that's a quick, concise of who I like to monitor.
I think it's a nice introduction to the topic, and I will go ask to Giuseppe. Victoria mentioned the poor grade patients, and I would like to ask you whether patients who could be clinically assessed or those who are not sedated, whether you would still consider in some of those neuromonitoring and which one?
I think if you think of a word to monitor is to have an alarm, to have something that give you a warning of something is going to happen. And if we think to intensive care, and not only neuro-intensive care, but also general intensive care in the patient not sedated and awake, I think the most important evaluation is the clinical evaluation to be done frequently, also in patient not admitted to the unit for neurological problem, because you can discover some subtle changes over time and some diseases, also complication of disease. Think about sepsis, you wrote about it. Think about sepsis, the patient with sepsis is not sedated could be also have an involvement of the brain. So I think neurological exam, we have easy accessible also the pupils. We can take a look at the pupils frequently. And as Victoria said, you need to tailor your approach to the single patient. If the patient is awake and is in a subarachnoid hemorrhage, as he said, I will look at the flow with some techniques, usually non-invasive if the patient is awake over time. If the problem is cardiac arrest, for example, and the patient is without sedation after TTM, I would like to have an EEG, non-invasive documentation of the brain activities. The patient is not recovering very well. So I think you need to tailor it, but the answer in the awake patient is for sure, at least you have to take a look at the patient frequently with a clinical exam of the pupils. Then you add on the top on it some non-invasive techniques because the patient is awake and you don't want to make a burr in his head, because I think we need to be less, because he's awake, probably he's less sick than other patient. So I think we need to tailor to the single pathology, but the message for the general intensivist, don't forget the brain.
Of course, that's very relevant. Victoria, Giuseppe underlined the complex issues of awake patients, and he's also said that probably we are going to non-invasive monitoring. He mentioned maybe echography for the flu and EEG for some other diseases. What about severe patients, those who are poor grade, whatever would be a TBI on SIH? Would you agree to go more invasive? And if it would be more invasive, which kind of monitor would you use?
Yeah. So, I mean, I think they were all really great points. And actually, I think taking on about the alarm perspective, right? I always talk with my general intensive care colleagues about, think of all the alarms that we have for systemic parameters, like the ART line going off and the SATS probe. And really in neuro ICU, I find that the really interesting thing is that kind of black box of a comatose sedated patient, where I really don't know what's going on. And like a million neurons could probably die quite quietly without any alarms. And that's where I think neuromonitoring really comes to the forefront. And so I think a combined approach, right? I think it's always easier if someone's going to put in a ICP monitor, especially for subarachnoid patients, to think about a bolt with a number of lumens there for brain temperature, LICOX monitoring or brain oxygenation monitoring, as well as ICP, to really give us that spectrum of flow, pressure, oxygen, temperature, which is really, I mean, the standard of care, at least in our systemic parameters. And there's not great evidence to show that we should monitor that continuously in a continuous fashion for systemic parameters. And yes, we might not be there from a brain perspective with a great level of evidence, but I feel like my hands are tied behind my back if I have nothing really to direct care, right, in these comatose patients. And it's even the thought that they may be deteriorating, because as I said, they can very quietly smolder with their brain injury and you don't detect these things. But then I think, as I said, a dynamic approach of combining invasive and non-invasive. So just as important, like transcranial Dopplers, as well as EEG monitoring, maybe in the subarachs, as well as just looking at your overall level of brain activity, looking at like alpha variability, so signs of ischemic patterns. And that would be my approach within the comatose or sedated patients.
I think maybe Giuseppe can also comment on that if he wants, but the question that I have for him, because we are a little bit neuro guys, so we like, of course, the understanding in depth of a brain derangement. My question would be, for those who are not convinced, one issue is that we can monitor, so I like the concept of alarm, but you should use these values to change or modify your approach. So you should protocolize your care based on this different information. We know it for ICP, there are different ICP approach, but this is true for all the neuromonitoring. And if yes, which ones, Giuseppe, would you use to potentially change your care, your management in these patients?
As said, we have different tools, and each of them is looking the single phenomenon or a combination of phenomenon. And coming from the idea of having an alarm, you have to react to the alarm. I was thinking, for example, EEG. EEG could be used by the neurologist only for searching for a seizure, and then you have an idea of starting a therapy for a seizure. In SIH, you can use it as an alarm of reduction of flow, potential DCI, and so you start a therapy increasing the pressure. So the same technique could produce different effect in different situations. I would like to ask a point, because we discussed, I think, a couple of days ago about the Synapse ICU study that is going to be published. And I think we try to, and I invite you, all of you, to take a look at it on The Lancet Neurology mid-June. And we were able, even if it was observational, to see that the value of being monitored and having a therapy applied, and we didn't specify a therapy because it was an observational study, was associated with improved outcome. And what everything we did also with the Seattle consensus was to put in order some strategy to be less aggressive at the beginning and to guide in response to an alarm, the clinician to find a way. And what we depicted with the Seattle consensus is there is not a single way for answering to the problem, but you have to put your brain and say, okay, I have an alarm, I have a problem in the patient, I have to understand which is the best intervention for obtaining the best result for this single patient. So I think for sure, we will answer with therapy, but the therapy needs to be tailored to the single patient and to the single pathological problem the patient is experiencing.
Thank you, Giuseppe. I have a question for Victoria, because We, of course, discussed a lot of primary brain injury, and some of our colleagues do not take care of those patients. And the question I have is, do you think that patients without primary brain injury also deserve to be monitored? And if yes, which kind of diseases should be monitored? Which kind of patients should be monitored in this setting?
Yeah, you know, although we maybe don't think of them as a primary brain injury, I think of cardiac arrest, right, with a hypoxic ischemic brain injury and their ischemic reperfusion injury. And I think we focus so much on the heart in that perspective, although TTM has brought maybe the brain to the forefront, but the majority of them do die through a process of secondary brain injury. And I think that at least in that forefront, there's been a lack of neuromonitoring in that area. And some of my colleagues actually in Vancouver, Don Griesdale and Amit Sekon, have done some great work actually using invasive neuromonitoring to really bring some physiological insights, right, to the cerebrovascular pathophysiology in that disease. And I think Giuseppe said earlier as well, like even our septic patients, right? We know that, like, why do we think the brain is special in general critical care, i.e. it's exempt from organ injury, right? We see organ dysfunction in sepsis patients from an acute kidney injury and liver dysfunction. The brain is, for me, the exact same, right? And the brain dysfunction that comes from septic shock and all of these other systemic critical illnesses, I think the brain is not exempt. And I think that it does suffer from secondary brain injury processes. And I think that we're only just starting to bring that into our kind of vocabulary to talk about it in general critical care, to really look at brain injury associated with our general critical care diseases. Thanks
a lot. I think most of us will totally agree with you about this very important point. I have a last question for Giuseppe. Giuseppe, we mentioned some of the issues related to monitoring. I mean, in clinical practice, sometimes the interpretation is complex. How to integrate all these parameters together with systemic ones at the bedside?
I think we started before this century to put together all the information in the information system you have in the unit, because you have something that synchronize the timing of the event of the systemic parameters and of the brain parameter. For example, having the rise of ICP, I take immediately a look at the arterial pressure, at the CO2, at the temperature on the same time, and there is no a single device or a single tool that you can use at the bedside. But my suggestion is to have something networked at the bedside, not a single trolley. The bed, even some trolley are very fancy. They have a lot of tools. I would like to have it on all the patients. And when I review the cases with a resident, the synchronization of the information is the most important part of it, because you look at the timing and the relationship between the event and what you did in the past and what was the response. For example, only a single infusion of osmotic therapy, we will take a look how long it lasted, what is the peak, the lowest value was the arterial pressure, you look at the diuresis at the same time. So you have to put in the combination of the elements and the computerized system. I don't have any specific recipe, but you need to record them and to make them synchronize in time.
And I think we all agree that we still need doctors at the bedside to take care of these patients rather than device. So Victoria and Giuseppe, I really want to thank you for these very great advices in this topic of brain neuromonitoring. And I hope to see you soon face-to-face in a meeting, and it will be also a pleasure to welcome you in the next eICSM chat. Thanks a lot.
Thank you very much, Fabio. Ciao to everyone.